Hello everyone, today I'll be taking another VivaLive session with QQSphere on the subject of pathology with the topic cardiovascular pathology and subtopic myocardial infarction. Let's start.
Welcome, doctor. Today we are discussing myocardial infarction. Can you start by explaining the typical pathogenesis of this condition?
Yes, the typical pathogenesis of myocardial infarction is atherosclerotic plaque disruption, thrombosis and occlusion, then myocardial ischemia, then necrosis.
That's a very accurate sequence. Can you now describe the sequential changes in macroscopy and microscopy in the first few days after an MI?
Yes, the key changes after MI are cardiomyocyte necrosis and apoptosis. There is inflammation from days 1 to 2, where immune cells like neutrophils and monocytes infiltrate the infarcted area to remove debris. Then there is scar formation after the 4th day. Myofibroblasts produce collagen to create a non-contractile rigid scar, replacing the dead muscle to maintain structural integrity. Then there is cardiac remodeling and neovascularization.
That's a good overview of the microscopic changes. Now, can you elaborate on the gross or macroscopic appearance of the infarct over time? For instance, what would you expect to see after 24 hours versus 1 week?
Can you please explain?
My apologies. I meant to ask you to describe the changes you would see with your eyes on the heart surface without a microscope. After about 24 hours, you might start to notice a pale, discolored area. By about 1 week, this area begins to appear softer and may develop a yellowish center with a hyperemic border. Later, as you mentioned, a firm grayish-white scar forms. Given that, and what you know about laboratory markers, which ones are most commonly used to diagnose an MI acutely?
To diagnose an MI, cardiac troponin is gold standard. It is highly sensitive and specific to cardiac muscle. Levels elevate within 3 to 4 hours and can remain elevated up to a week or two. Then there is CKMB and also myoglobin.
Excellent. Cardiac troponins are indeed the preferred markers. Now, considering the potential complications, what are some of the early structural problems that can arise in the heart following an extensive MI, particularly relating to the ventricular wall or papillary muscles?
Yes, there is cardiac remodeling, which causes
Yes, remodeling happens, but more immediately, there's a risk of myocardial rupture. This could lead to rupture of the ventricular wall, causing cardiac tamponade, or rupture of a papillary muscle, leading to acute mitral regurgitation. To conclude, what are the main causative factors behind the development of the initial atherosclerotic plaque itself, particularly the modifiable ones?
A vulnerable atherosclerotic plaque ruptures or erodes, and it is due to severe ischemia or atherosclerotic disease, diabetes mellitus, obesity, etc.
You've correctly mentioned some important risk factors like diabetes and obesity. Hypertension, dyslipidemia, and smoking are also major modifiable contributors. That concludes our examination. Thank you.